Well, good evening, everyone. My name is Dr. Hector Flores. I am the member of the LA County Medical Association Board of Directors, and along with Dr. Omer Deen, who's our president, I'm the co-chair of this educational series. Dr. Deen is on the road, so he may not be able to join us till later, but he sends his greeting to everyone, and he especially wants to thank Assemblymember Ash Karla for presenting this evening. And Gustavo is on the road as well, so he'll be joining us shortly. I want to thank you all for joining us tonight. We really appreciate the questions that many of you submitted in advance. We will be using those when we get to our question and answer session. But it's a real pleasure to introduce Assemblymember Ash Karla, who was first elected to the California legislature in 2016, representing the 27th Assembly District of California, which encompasses about half of San Jose and all of downtown. And that year he made history. Assemblymember Karla was the first Indian American to be elected to a state legislature, and continues to be a pioneer in many areas accordingly. In 2020, he was reelected for his third term, reflecting the confidence his district and constituents have in his work. Assemblymember Karla is chair of the Assembly Committee on Labor and Employment, and also currently serves as a member of the committees on Housing, Community Development, the Judiciary Committee, Transportation, and Water Parks and Wildlife. Assemblymember Karla has a long and illustrious history as a leader in issues ranging from criminal justice reform to the environment, to healthcare sustainability, housing affordability, growing our transportation infrastructure, and expanding economic opportunity for all Californians. Assemblymember Karla previously served on the San Jose City Council for 8 years and was a deputy public defender for 11 years in Santa Clara County. So he has been a public servant for over 25 years. He is, of course, well known to all of us in the healthcare community because of his leadership and courage in authoring AB 1400, the latest iteration of a single payer proposal for the state of California. And we're really happy to have him and honored that he's presenting on the title of his talk, Single Payer AB 1400, What Happens Now? Welcome, Assemblymember Karla.
Well, thank you so much for inviting me for part of this important conversation and speaker series. And, I wish all of the regional and local medical associations would be as open to have these conversations. And I think we are definitely seeing, as the years go on, more and more sincere conversations from our medical professionals in this space. And for that, I'm very grateful, because obviously, single payer healthcare or any significant reform to our healthcare system not only wouldn't be possible, but it really shouldn't be done without engagement from those on the front lines, our doctors, our nurses, those that are assisting our doctors, those who are making sure our hospitals and clinics are functioning. And as you know better than I do, that takes a lot of people. Although I do think that the voices of our doctors and nurses are the most profound, given the nature of what we're talking about. And so I want to speak for a little bit about kind of, the history. I think a lot of you probably know, but I do want to give some background, not just on AB 1400, but kind of on single payer healthcare in our state. And I think, again, a lot of you have been engaged in that, so I don't want to spend too much time on that, on things that you're already familiar with. But there have been a number of efforts to put forward single payer healthcare in our state. And AB 1400 was the most recent iteration of that. And I think the best ever, I believe, in terms of the language that was put forward, and the significance of the level of detail in CalCare. I'm very proud of that. The nurses worked tremendously hard on that, as well as other stakeholders that were giving feedback and what have you. And I think it's because of that there was a lot of momentum that was created in terms of the policy and in terms of what CalCare would provide for. Now, there's been a lot of conversation in recent years, even before AB 1400. We know when Governor Newsom was campaigning for his first race for governor, he was very proudly in support of single-payer healthcare. That gave a lot of momentum in terms of bringing forward a bill. Now, when I first got elected, SB 562 was on the table, and unfortunately, did I have the opportunity to have a hearing on the Assembly side, and I think even more unfortunately, in the months that would follow, we recognized that with the new administration in Washington, D.C., I think a lot of single-payer advocates, a lot of folks that were on the front lines, including the nurses, and many advocates realized that the most important thing at that moment was to fight to prevent a degradation of our healthcare, to fight to protect Medicare, fight to protect Medi-Cal, fight to protect the floor, as it were, the basic necessities, because they were certainly under attack during the Trump administration. And I mentioned that because it speaks to why if 562 wasn't successful, why a bill may not have been introduced the next year or year after that. And I think it was because we were in a different place at that time. We recognized that not only was healthcare under attack from the federal administration, but in order to have a successful single-payer plan presented at the state level, you needed cooperation from the federal government, and we certainly weren't going to get that during the Trump administration. And so when we fast forward to 2020 and the election and swearing in of President Biden, I certainly saw an opportunity to re-engage on the issue of single payer. I think the nurses felt the same because ultimately you cannot be successful without an administration. What I mean by that, and many of you may be aware of this, but the Department of Health and Human Services in particular has to approve a waiver, a federal waiver, in order for any one state to be successful in putting forward a single payer healthcare plan. The state of Vermont was able to actually successfully get a federal waiver when they put forward a single payer healthcare plan. Unfortunately, on the financing side, because it is a political hot potato, no doubt about it, that they had to abandon their plans because it just wasn't palatable for them at the time to be able to put forward a financing mechanism for their single payer healthcare. But we already know there's precedence for the federal government approving a state trying to move forward with their own single payer healthcare plan. Now, when I introduced the bill in 2020, it was, the policy itself, I think, was very strong in AB 1400 with CalCare. And what happened after it was introduced was, as it approached the policy committees, the speaker wanted the financing to be included in the bill. Now, given kind of where we were in the policy committee deadlines at the time, into April, we basically only had about a week or two to be able to put financing in the bill and have it go through the Revenue and Taxation Committee. So it was at that time that I made the suggestion that we hold off and give more time for us to actually see if we can get two separate bills on financing and policy, AB 1400 being the policy, and rather than putting the financing into it, I believe if we did that, the bill would have been put dead in the policy committees. And so when that happened, it wasn't like we just said, okay, well, let's just hold it and bring it back later on. We took advantage of that time, especially during the interim. And for those that may not be familiar of the schedule, the calendar, the legislative calendar, we basically refer to the interim as the fall, September, October, November, December, when we're not in Sacramento in session. Right now, we're in the interim right now, although I am in Sacramento today. We're in the interim until we get sworn in to our new 2-year session. And so during that time in April, we spent the next few weeks and months focusing on other bills. And the nurses had some of their priority bills. I had other bills as well. But we also continued our conversation. Okay, what do we do with AB 1400 at that time, and how do we reconcile having to put financing into the bill? And so during the course of the fall, I did go to Canada, Quebec and Ontario. I also went to New York City, as well as Washington, D.C. And I think Washington was the most relevant aspect of my kind of East Coast swing, so to speak, because I had the chance to sit down with Department of Health and Human Services, one of their folks, right under Javier Becerra, the secretary, who actually operated the Medicare plan, and they had their deputies and folks in there that actually operate the waiver plan. And so what was significant about that trip, even though we knew on paper that we could put forward a policy plan at a state level and get the waivers without having funding figured out, we wanted to make sure that we had the confirmation as much as possible. And so we met with Health and Human Services. They confirmed that a state can just go forward with the policy bill as long as they have some sense of what they're going to do with financing. And so we come back October, November, continuing to have meetings with colleagues. I was meeting with colleagues throughout the interim, and was able to, by the time we got to December, get approval, get support from the speaker to be able to have two separate bills, which is really what we were asking. When I say we, it was the nurses, California Nurses Association, and myself as the bill author, kind of get the authorization to have two separate pieces of legislation, one being AB 1400, the policy bill, the other being a constitutional amendment, which had the funding mechanism in it. The reason why it's a constitutional amendment is because you literally have to deal with not only the funding the funding in terms of what it would look like in terms of the taxation mechanism, but you have to have a constitutional amendment for the GAN limit and Prop 98, which mandates a certain percentage of our budget to go to education. Well, the only way to get around that, to get around those two issues, is to go to the voters and basically say, hey, we want a constitutional amendment in this case, for the purposes of healthcare, and creating a CalCare trust fund. We need amendments to allow us to do that, to get around state law. Additionally, we needed to go to the voters on the funding mechanism themselves, on taxation. And the significance of that is that in order to put to get it to a vote of the people, you can have a majority vote to send it to the voters. Of course, you would need 2/3 of the vote on taxation, which is a pretty heavy lift, but that's part of this part of doing this is being a movement. If we can't convince the people that it's something important, then it's going to doing such a major transformation of our healthcare system. It's not something the legislature itself is going to do. They're going to put it to the people, and I'm fine with that. Although we know that if we do that, we'd be facing hundreds of millions of dollars in opposition. But that's where the movement, the grassroots, takes form. There's a reason why Bernie Sanders won this state. It wasn't because he had more money in the state. It's because the grassroots supported some of the initiatives like single-payer healthcare. And so we would have to kind of activate that same kind of network in order to be successful. And so we get to January and introduce the funding bill separate from AB 1400. It did put us in quite a challenging position because now we only had a couple weeks. But we had to get the policy bill through the assembly by the end of January. And the political challenge that occurred at that time is that now we have a couple weeks not only to get the policy bill through the legislature, but we now have this funding mechanism that's out there, publicly put out there. Although we don't need to vote on that before the end of January, the majority of questions we're getting from the media, from my colleagues, and what have you, has to do with the funding mechanism, because obviously that's the most kind of visceral reaction you get from folks. Oh my God, you're going to tax this and tax that, and it's going to be, a tax that's going to be $200 billion or more. And even though the system itself would cost, over $400 billion or more, we know that we would get the majority of that from existing funds that we're already paying for healthcare, from Medicare, from Medi-Cal, from all the different systems that we have. You cobble that together, and that's well over $200 billion. But you still have to make up the difference. And when folks say, "Oh well, how are you making up if single payer healthcare, if CalCare is cheaper than our current system, then why do we have to make up the difference?" Well, the reason is that you're getting rid of employer-based healthcare, all the co-pays, and you're getting rid of all the premiums. Employers pay an enormous amount of money into the healthcare system. And so this would be in lieu of that, not in addition to that. And that's really something, and I know there's some questions that will probably get into some of those details, but the reality is that right now, employers pay an enormous amount, as much as 20% of their costs, employment costs for healthcare and healthcare premiums for their employees. Well, that would all go away, which, if you think about it, is a pretty great incentive for employers, especially large employers. Now, it's not a great incentive for what I may refer to as the bad employers, the McDonald's, the Walmarts, and all that want us, collectively us as Californians, to pay for their workers' healthcare through Medi-Cal. They rather have it taxpayer funded. And they do that by not giving full-time employment to their workers. That's why so many low-wage workers have to have 2 or 3 jobs. 20 hours here, 18 hours there, 20 hours there. It's because a lot of the employers want to be free from having those same obligations that all of you may have as employers, or your employers may give to all the workers that work at the hospitals or work at the clinics or work at the county public health care system. And it's not fair, frankly, for these some of the wealthiest companies on earth to avoid their responsibility to their workers and instead put the responsibility on us to have to fund their health care. And so, that was part of the challenge and why, when we got to the end of the month, and even though, we got it through the health committee, which was extraordinary, got it through the appropriations committee, literally, a week later, and then days later had to go to the assembly floor. It's hard to articulate how hard it is to even get that far, but also to get enough votes when it's coming that fast and furious to our colleagues, especially when the governor, kind of publicly said he wasn't supportive. That was pretty harmful to our efforts at the time. Still committed to working with the governor and getting the governor there. But at that moment in time, it made it really challenging to be able to get enough commitments from my colleagues. And keep in mind, we were also 4 colleagues short, and they were all Democrats. So we were 4 votes short. Trust me that, going from 60 to 56, having to get 41 votes made it enormously more challenging to be able to get enough commitments. And so we didn't have the votes to take it up. And I made the decision, not the nurses. And I know they were clearly not very happy with me, as were a lot of other people weren't. But the reason why I didn't take it up is because we knew we were dramatically short of votes. We also knew, and there is, and believe me, I believe there is a value for holding folks accountable to their vote, whether a bill gets passed or not. I absolutely think there's a political value to that. However, my focus was on passing the policy, and I knew that even if we got a lot more supportive colleagues, which we are getting, which we all could foresee coming, we knew we were going to have a significant number of the incumbents to support us the next time around. And so I do think that we have, as predicted, a lot of really good colleagues coming on board that give us more support. We're hoping Pilar gets elected. I know the numbers are looking better and better, but she's not there yet. I'm really, that's a huge boon, huge, not just for healthcare, but for a slew of other issues. I think that's the biggest flip we can possibly get in this state, is for Pilar to get elected and oust a Republican who would never be there on a wide range of issues, including a lot of the issues I know you care about in terms of healthcare access and expanding Medi-Cal, expanding reimbursements, Medi-Cal reimbursements, and on and on and on. More transparency in healthcare costing, and so we're all crossing our fingers and praying that Pilar gets in there. But she's not the only one. There are others that got elected I think are going to be really helpful to the cause. And I think that there is a number of folks that, again, because of that contracted timeline, weren't quite there yet at the end of January, but I strongly believe we can get there, especially if we can get more and more colleagues very vocally in support. It really moves the needle and builds momentum on trying to get it passed. And I would say that now, and I have had I just met relatively recently with the new representative from the nurses. I'm still fully committed to running a bill. Obviously, there's a lot of conversations that have to take place, including whether the timing is right to do it right now in January or not. I'm fully committed to doing it in January, but some of the issues that kind of have to be considered includes having a new speaker coming in, and whether it makes sense in the final 6 months. You may have heard the news that Robert Rebus will be coming in as speaker June 30th. So does it make sense to introduce the current speaker? Or those are all conversations that are going to be we're going to all have to have and figure out strategically what makes the most sense. The good news is that Robert was a substitute in the Health Committee and on the Appropriations Committee, both of which he voted to support AB 1400. And whenever a bill of this nature comes before a policy committee, and sometimes someone is put in as a substitute, usually it's because they're supportive. You're not going to put someone in there that to take a tough vote that they're not supportive of. And so Robert is someone I'm very close to, and I believe will be part of the solution and how we can get something like this through the assembly. But those are part of the considerations we have to have, and we can talk a little bit more about that because I think there's some questions in that regard in terms of what's next. And so I just want to put that out there, and we can obviously have further conversations. So I want to stop now because I know there's a lot of great questions, and I'm more than happy to continue the conversation.
Well, thank you so much, Assemblymember Karla, not only for giving us the behind the scenes perspective and the timing pressures that you were dealing with, which were not readily apparent to the public, and for sharing your deep knowledge of these issues. And that's leads to the first question that was submitted. Healthcare in the US, and California is no exception, is a highly complicated process. Financing, delivery, and all the special programming that occurs. And we noticed that you were the spokesperson for AB 1400, rightfully so, but a lot of your co-authors were not that vocal or visible in supporting this. And a lot of folks were wondering whether they really understood the bill and were able to speak about that. And so could you comment on that and maybe why they they let you take the lead on that and weren't as visible?
Yeah, it's pretty common. Like, look, everyone has their own bills and their priorities. So I kind of get that, but this was not like any other bill, which means a couple of things. One is it's a lot easier to kind of be a public cheerleader of the bill. But when it comes to doing substantive work, it's a lot of work. I think that I knew the bill, there's no doubt, kind of better than any one of my colleagues, as I should, but that took a lot of work. And I had, almost my entire staff working on the bill in different aspects, the policy aspects, the kind of the communications, the comms area and all that. And so it definitely helps to have more surrogates with the bill, but it's hard to be a surrogate on a bill of this nature and understand all the complexities of it. It takes a lot of time, a lot of energy. And I'm not gonna, kind of criticize all my colleagues that are supported for that, because again, like I said, they also have priority bills. They have complex bills that they need to be, that they're authors of. I do think that we have the opportunity to have more folks engaged. I do think having folks like Pilar in there will be incredibly helpful, as well as others that I think have that already kind of walk in but with some more in-depth knowledge, because it is challenging to field questions from constituents. There are very difficult questions. And it's really challenging to talk to my colleagues, try to get them on board when our colleagues have very detailed and challenging questions as well. And there's no doubt that it was a challenge to have enough people. Like, everyone plays a role. You have like an army of folks, but you do need a certain number of folks with expertise. The nurses are fantastic, and they did have some folks that had great expertise, but they had a limited number of folks that really can handle the level of detail, only because this is a living, breathing document and policy, right? Things change, and so, you may be very well aware of it and knowledgeable of it, but something changes, then and you're speaking to it the next week, and you may not be aware of the most recent changes to it as well. It's not like any other bill, and you cannot, it's very challenging in terms of, you have to have incredible credibility in talking about the details and down to the micro level of the bill, and that can be really challenging. And I think more so than most, this bill got looked over with the fine-tooth comb, which makes it hard, and I think it makes it kind of puts an unfair burden to some extent, all the co-authors and the joint authors, because they're expected to know every single detail, and that's just not the reality of a policy, even of this nature, because some of the details, really do get in the weeds. But that being said, I would hope that we have more folks that will be more engaged, not just publicly, but on the policy side. And that, that takes a lot more work from my end, and I'm happy to do it. I did have regular weekly meetings with that was open to all the co-authors. The extent to which they joined or not was their prerogative, but I was definitely as available as I could be in terms of making sure that my co-authors were aware of what was happening with the bill, and being there to help inform them on what they can do more in getting more folks on board.
Senator Ted Kennedy used to say the reason he focused on healthcare, and not only because it was important, but because in his career he had seen a lot of good ideas and good bills die on the road for lack of a voice, right? And you become that voice, which is fantastic. But there's an opposing voice, which is a narrative of single payer means massive taxes, and you've touched on it a little bit. Secondly, it's government-run program, right? A third, the providers are worried that payments will start to ratchet down. And the fourth one always says this is government-run government-run healthcare. How do you address that with your colleagues, and how would you propose we address that with the public?
Yeah, look, starting with the kind of its massive taxes and what have you. Look, the reality is that we pay the highest health tax in the world right now. It may not be called a tax, but the reality is the burden on the average business, the average individual, the average family, whether it's because a business has to pay for healthcare for their worker, whether it's because the individual employee has to pay a whole bunch of money for their healthcare through premiums, through co-pays, what have you, or if it's because someone doesn't have healthcare, that's the highest tax of all. They don't get access, or they don't get the same kind of access, or they don't show up to their appointments because they can't afford it, or they end up dying because they're making choices that are detrimental to their health, that their doctor says, these are the steps you need to take, these are the things you need to do, these are the medications you need to purchase, and they're making choices at the kitchen table to survive, and they die because they can't afford it. And so we have to change the narrative. And I really appreciate, the calculator was one thing that we were kind of really hoping for last year. We were able to get on board. It cost a lot of money and all that. I'm glad that we were able to get something on board. And I do agree with one of the comments that we need to do it for employers as well, because employers pay a whole lot of money for healthcare, and their costs would go down. And so we need to educate that, yes, there are a lot of taxes involved, but the net savings is much greater for the individual and for the companies. And so the current healthcare tax is killing people and killing businesses. And I think that's how we have to kind of counter that. And it's not government-run healthcare. There's a board, certainly a calculator board, which would be an independent entity with the sole purpose of making sure the payment for services are paid and the state is addressing inequities in our system and planning for future challenges. But the CalCare is not the delivery system; it's the payment system. And so we do believe that publicly funded healthcare is a human right, but not necessarily. But it's not that the service itself would be public. Although we have fantastic government-run county programs, county hospitals, clinics, and that shouldn't change. We also have fantastic privately run hospitals and service delivery, and that will not change as well. It's really it's how people are getting paid and what they're getting paid, which goes to your other question, which is, will providers be paid the same? And right now, look, Medi-Cal, Medi-Cal severely underpays our service providers. That's why there's so many service providers that don't accept Medi-Cal. It's not that they don't want to. I know every doctor wants to take care of the poorest in their community, what have you, but if we're not reimbursing enough, it's impossible. And I know a lot of doctors that take as many as they can, but they can't survive as an office. They can't pay their staff. They can't be compensated well as they should be for serving their community. And so we take that into account in CalCare. And we want to get rid of Medi-Cal and instead have CalCare, where the formulas that are created get based on as a floor off of Medicare reimbursement, but as a floor. I make that very clear, because it's not like it's just Medicare. We think the doctor should be paid more. We don't, Medi-Cal reimbursement is not enough. And when folks say, well, how can you pay for it? Well, we can pay for it because right now we're paying more than any other country in the world. We don't need to be paying this much for a healthcare system. We can pay our service providers, we can pay our doctors and our nurses more, and take away as much as 20% of administrative costs. And of course, the enormous profit that's going to those that are not providing the care. The insurance companies or the hospitals that are taking so much from the bottom line. I'd rather go to our doctors. I'd rather see us focus more on primary care. Primary care, primary care doctors, or a lot of folks become specialists or don't become primary care doctors because they don't get paid enough. That's true. We need to pay primary doctors more. And I don't want to see a comment is made, administrators who process claims. You go to a doctor's office now, I just know, because I take my dad to the doctor on average once a week now. Eye doctor, hearing, dental, which is a whole other issue, stomach issues, his cardiologist, you name it. And the office has 3 times as many administrators as healthcare providers, as doctors and assistants. I know, and I've talked to doctors, they want to spend more time with their patients. They don't want to have to deal with paperwork all the time. But think, if we think about, and this is why you all know this, but I say this, kind of to the general public, think about how much we can save if you get rid of all those administrators that are just taking care of paperwork to see if you qualify for this, that, or the other, checking what insurance you have, checking what's in network. You get rid of all of that and put that towards purely going to your doctors and your nurses, your physician's assistants, your dentist, and have it go to the ones that are providing the care. And you can do all that and compensate better and still save money through a system like CalCare. And so that's what I would say. I would say that we have to be very clear. We need the doctors' voices to be on board and to make it clear about how much we're wasting without being able to provide care to every single Californian.
Absolutely. And the rationale is pretty clear. And one of the questions that came through is, would Governor Newsom sign the bill if it was passed by the legislature? I know he's made comments that there's a lot of barriers that would need to be cleared. You mentioned getting a DHHS waiver, but also ERISA, the Employee Retirement Income Security Act, which employers, and multi-state employers, they like the control of buying their own health insurance. And so what are some of the stepping stones to have a product that the governor would sign?
Well, that's something we probably need the governor here to ask. But at the end of the day, look, federal waivers, is huge, as you know, as all of you know. There are plenty of federal programs that It's not just Medicare. It's not just Medi-Cal at the state level. There are a number of programs which are fantastic. And by the way, which we've gotten waivers for in the past to allow us to expand coverage to our California residents. And so the reality is that we would need the governor to ask for those waivers, but the governor cannot, and this is a difference of opinion we have with a lot of folks, but the governor cannot ask for a waiver without legislative authority. I literally sat there, we had a meeting for an hour and a half or longer with the Department of Health and Human Services. I asked the question 4 or 5 times just to be extra crystal clear. You have to have legislative authority in order to apply for federal waivers. And I made it clear, what does legislative authority mean? Does it mean that you have Ash Karla ask for it? No, it means you need a bill that's passed by the legislature. And so that's the first step. We have to get AB 1400. And I think if we can get CalCare passed without the funding mechanism as part of it, I think that hopefully we can get the governor to sign it just to get the waiver application applied for, so that the governor can say, look, okay, you know what? I'll sign the policy bill, but if we don't get the waivers, it's a no-go. I agree. That's fine. It's a no-go, but at least let us start that process. And we can then worry about the financing mechanism later. And when I say worry about it later, I don't mean we put it on the back burner. What I mean is we can work on the ACA, the constitutional amendment, similar to what we did last year, but we don't have to have it all figured out yet. We don't have to have it approved by the voters yet, because that's just, honestly, that's way too much to get done by the nurses, by any author of the bill, by supporters. It just is. And I think it destines it for failure. But it doesn't mean that I will shy away from putting funding mechanisms forward. We did put our funding mechanism forward that had to do with gross receipts tax, personal income tax, and a payroll tax. I'm open to debate it. These came from the study that was done from the Poland study, the University of Massachusetts professor that did it in regards to SB 562. He had there was basically a menu of different financing mechanisms, including sales tax, which I did not like, because I think it would be too hard to pass it. I think it's far too regressive. I think too high of a payroll tax disincentivizes hiring. That's why we have it just at 1.25%, which is far less than what employers pay, which is anywhere from 9 to 10% of payroll right now for healthcare. So I think it's a much more modest. Gross receipts tax would be a big tax burden, but it can be far easily kind of spread across the economy. And then it includes companies like Walmart and McDonald's that refuse to pay for healthcare. It's not fair to all of those that you do pay for healthcare for your employees. So anyway, there's a number of things, but ultimately the governor will sign it when we have to put the pressure. Okay. It's going to take a movement of us to get the governor to sign something of this nature.
Well, thank you for that insight. And, talking about the financing, the Healthy California for All Commission report came out in 2020, I think did a really good job of doing the assessments of all the different components of financing. One of the issues that has concerned many physicians and medical societies is the issue of governance in AB 1400, the 9-member board being political appointees, no guaranteed position for a physician. There's a healthcare provider position, but that could be a nurse practitioner or a PA, a dentist, et cetera. So governance is one issue. And then the advisory committee, which is appointed by the governing board, is likely to be people that think the same way as the governing board. Could you address those concerns that physicians and hospitals feel left out, and how you might adapt or reassure them that they'll be adequately represented?
Yeah, I think it's hard. Well, that's a very fair question. It's one that I've had conversations with, including with physicians for a national healthcare program, with my own local doctors. There can be potentially as many as 5 physicians on the governing board, but you are correct. There's nothing that guarantees that. And what I mean by that is that it requires 2 healthcare professionals who practice medicine. Well, clearly that could be a physician. 1 public health professional could be a physician. 1 member with the institutional provider background, again, could be a physician. 1 member of the advisory committee who could be a physician. I'm more than happy, and I've said this, to have something more concrete to guarantee at least 1 physician of the 9-member board. I do think that given what the requirements are being asked, it's likely there would already be probably at least 2 or more physicians. But if I'm a physician, if I'm a doctor, I would also be a little bit wary of it not being very clearly codified. And so that's absolutely something that I'm more than happy to continue to work on with physicians to have greater specificity, including greater specificity in terms of the advisory committee. In terms of the appointees, look, I mean, it's somewhat hard to get around that. I think that when you have something of this nature, now look, you're always going to have influence, as you should, on those that do the appointments. It's really hard when you have something of this nature, especially given the amount of funding we're talking about, to take the appointment power away from the elected officials. Look, at the end of the day, we work at the service of the people that elect us. And so, that's where, it would be challenging to have someone in the governing board appointed outside of the legislature or governor. It's definitely something I'm open to having further dialogue on. I think that it would make it harder, I think, to pass in the legislature if you take some of that legislative authority away. And we have plenty of examples of appointments that are made by the legislature or governor that I think, whether it's the UC regents and a number of other positions, CSU regents, PUC, which may be an example of, may not be the best example, because I also have a lot of criticism at times of the PUC, but I think that there are dozens of examples of governing boards that are appointed from the legislature and governor that do have very competent private sector folks, have folks of incredible expertise that are in those positions. But that's something that I think, yes, I'm also would be more than willing to have further conversation on. And I understand why physicians would have the concerns that they do.
Sure. Thank you. And another question that came through was, a lot of the description in AB 1400 sounds a lot like Medicare for all, although you didn't really specify that. A lot of the questions were that Medicare works, that there's very few people that are unhappy with Medicare, from physicians to the patients themselves, to even the health plans that participate with Medicare Advantage, for example. Do you see that potentially being the model, or was there a reason you didn't really call it that?
Well, we didn't call it because it's not going to be Medicare for all, right? I mean, it's not like at the federal level, you can say Medicare for all because it literally, you just have to expand it. You can reduce the age to 50 years old. There's plenty of ways we can actually legitimately and frankly, if we were able to do that, like if I could snap my finger and make it Medicare for all at a federal level, I would do that, but it's not Medicare for all. I want to make it better than Medicare. And what I mean by that is, like, my father just had to have a root canal, and he's about to have 3 teeth extracted, and we're probably gonna have to do implants. I mean, it's just a mess, right? And as you all know, it's not covered under Medicare, and he had to pay a lot for insurance. Otherwise, he was gonna have to pay thousands of dollars for dental care. Well, under CalCare, we want those types of services to be covered. We want hearing. My dad had to pay, $6,000 out of pocket for his hearing aids. We want some of those things. We want those things to be covered. We want a more mental health care for all ages to be covered. We want long-term care. I used to chair the Aging and Long-Term Care Committee. Long-term care is unsustainable in our state and nation. People are going bankrupt. People are going poor. People are becoming homeless. I've literally met people that have become homeless because they need long-term care and their family members can't take care of them. It's heartbreaking. And so it's better than Medicare for all in that sense. We can make it better in California. We're about to become the 4th largest economy in the world. And so it's Medicare for all plus.
Yeah, thank you. And one of the elements in the bill also was to eliminate health plans. And there's a lot of concern in 2 parts. One, that the health plans actually serve a useful purpose. They have IT systems that can track patients, patient outcomes. They have management that can manage population health and look at the accountability that you were mentioning earlier. And so there's a certain concern that we may be throwing the baby out with the bathwater by, just sort of universally saying no insurance companies. And would a single payer system be able to replicate what those health plans do well?
Well, look, let me give you an example of, I think, I get a lot of questions because I live in, the Kaiser territory. And so I get a lot of folks say, hey, you're going to take my Kaiser away. But I hear that whether it's from the healthcare providers that work for Kaiser or the patients, what have you. And I think, a system like Kaiser in terms of the healthcare delivery would work really well with CalCare, not the financing aspect side of it, but the service delivery side with, global budgeting and what have you. There's an absolute opportunity for entities like Kaiser or how Kaiser's delivered, or Santa Clara County and how Santa Clara County delivers healthcare. There are plenty of opportunities to maintain the manner in which healthcare is delivered. But I understand that it's really hard to disentangle that from the financing because, I get that it's going to be really hard to disentangle from the financing. But the reality is that that's where so much of the cost savings comes from, right? A lot of the cost savings comes from the administrative costs that it takes by unifying not just the payment, unifying the administrative costs, like the VA does, like Medicare does. That's where so much of the administrative waste happens. Not saying that all the entities have an enormous amount of waste, but having hundreds of paying a multi-payer system with hundreds of different payers is extraordinarily wasteful. And so I would say that there's a great opportunity for us, given the fact that healthcare plans do serve a function in today's system, because they already have the networks of providers, they already negotiate rates down and process payments. Under CalCare, the reality is that people would no longer have to worry about what's in network, and the system would reimburse providers based upon needed care. So, I think there's an opportunity to pivot what these healthcare plans do well into care delivery, as opposed to some of the things that they would not have to do, including in determining what's in network, out of network. They wouldn't have to worry about doing the heavy lifting and negotiating rates down. We can now negotiate on behalf of 40 million people. They wouldn't have to process payments. But I don't think that we should throw away everything that health plans do well, because I do think that patients do get served well in many cases in terms of the efficiencies that these systems can do.
Thank you. And another related question was that the bill also had a sort of a sentiment that you can only trust nonprofits, but you can't trust for-profits. And that would eliminate input from organizations like the Permanente Medical Group, which is a for-profit group, private practices that are serving 75% of Californians. How do you reconcile that with the goals of the bill?
I mean, I do think that, there are definitely folks in the progressive movement that would be much more mistrustful of for-profits. And I do think that, look, at the end of the day, there's a reason for that, right? I mean, I think that our for-profit system has provided, I think, the best healthcare on the planet if you can afford it, right? And so there's a reason why there's a cynicism and a skepticism to the profit taking in our healthcare system, where the fundamental sense that, look, if healthcare is a human right, someone shouldn't be denied it based upon whether there's a profit to be made or not. Now, that being said, I think there's a lot of issues with nonprofit delivery as well, right? That needs to be questioned. And so I think that I don't come from the angle that there needs to be a built-in mistrust. I think, honestly, that there are inefficiencies and issues of ethics that run the gamut from county systems to nonprofit systems to for-profit. I don't think we benefit from kind of the blame game and saying, okay, well, it's their fault. And that's what we got a lot of in putting forward this bill. The insurance company says, oh no, it's the hospitals, it's the doctors. the doctor says, no, it's the insurance companies and it's the hospitals. The physicians group says it's not us. We're efficient and we're representing the best of healthcare delivery. It's the pharmaceuticals, the drug companies. So there's a lot of blame to go around. CalCare is agnostic as to who should take the blame, but rather says like, look, we all know we can do better. Let's find a more efficient system that has cost controls, has cost containment, has auditing, but puts the power, I think, back into the service, into those that deliver the services, that has ability for special programs in rural communities and underserved communities that are not currently getting the services they deserve, and incentivizes doctors. I've talked to a lot of doctors, a lot of medical students that want to go into low-income communities. But it just doesn't pencil out. We have created a system that disincentivizes those doing the work that is most needed. And that's a shame. And look, I'm a lawyer. I worked as a public defender for 11 years. We do the same thing in the legal industry. And you all know it because you get sued by a lot of lawyers. Mm-hmm. We've incentivized those that are going for that are working for the firms and the partners that making all this money, as opposed to doing the work for the public interest. And gratefully, in places like Santa Clara County, we've compensated our DAs and public defenders enough, or where we've made it attractive enough for those who choose that line of work. But in some more rural communities in our state, we pay so little that folks are not going into public defense. Same exact thing can be said with medicine. And I think we've got to figure out how we can do better in letting those that are coming out of medical school, including paying down their medical debt, which we can do with CalCare. We can really incentivize more folks to go into healthcare by making the burden far less for them.
Absolutely. We appreciate the principles there. We have time for one more question, and it really relates to a coalition building to get support for this innovation. Obviously, the California Nurses Association, figures prominently. Other important organizations supported AB 1400. But absent was a visible support from the California Medical Association, California Hospital Association, California Association of Health Plans. In fact, all of them in one form or another have spoken against AB 1400. How do you get them all under the tent and have a coalition that actually looks forward rather than backwards or frustrating your efforts?
Well, I think that, look, we have to be realistic here. There's a reason why a single payer system or our current system, by different estimates, is anywhere from $30 to $50 billion more expensive than a single payer system would be, while not providing healthcare to everyone, and while people, medical bankruptcy, medical bills and medical costs are the number one reason for family bankruptcies in our state, and that hasn't changed since Obamacare and since the ACA has been in effect. That money is going somewhere. It's going to enormous profits for folks that do not want to see the status quo change. So I'm not going to be naive and say we're going to get, pharmaceutical companies on board, or we're going to get the California Hospital Association on board. I'm not. It doesn't mean I always hold out hope, but I'm not going to say, okay, our plan to get them on board is A, B, and C, because we have to be realistic. I do think that we can get a lot of healthcare providers, a lot of doctors on board. I think when you do surveys now, over 50% of doctors, a lot of them are younger doctors, are in favor of a single payer type system. And I've talked to a lot of doctors that have been practicing for a very long time that hate where the industry has gone compared to where they were when they were younger and working as a doctor. And so I think there's hope with physicians. I don't necessarily know if it's going to come from CMA, but there are other physicians groups. There are other. I think it gives me hope that the LACMA is having this conversation. There are so many of you that are supportive or want to know how you can be part of the solution. But there needs to be other voices at the table. CMA, CHA are not the only voices that bring expertise at the table. All of you bring an enormous amount of expertise. And there are a lot of other physicians out there that bring an enormous amount of expertise, the nurses, obviously. And I saw a note there, we absolutely have to bring more unions on board, especially given the issues of ERISA and the healthcare trust funds, healthcare funds that a lot of the unions have. We need them on board. And there's a lot of fear, understandably, whenever anything is changed. We saw this election cycle, people going after supporters of AB 1400 and CalCare, saying they're taking your Medicare away, all the fear mongering. And it's disgusting, honestly, to see that. we have to push back and say, look, if we want to have an honest conversation about this, we have to get rid of the fear mongering and speak to people's hopes, but do it in a way that's honest. And that's what I've always tried to do with CalCare, is not promise something that's not going to be there, and make it very clear that if this is going to happen, all of us have to fight for it.
Fantastic. Well, thank you very much. I see a lot of the organizations you mentioned, the Physicians for a National Health program, are planned here on our audience. The California Physicians Alliance, which has a report of a roadmap to universal coverage in California, they call it Golden State Care, as well as the Physicians for the Underserved. So you'll have a lot of allies in this. And thank you again. We really appreciate you taking the time to do this. So thank you
all
everyone
so
for
much.
joining us.
Really appreciate it. Great to see you all.
Thank you. Have a good night, everyone.
Bye.